In terms of like steroids, obviously that is the one thing that we've had studies that have shown that using 6 milligrams daily for up to 10 days of dexamethasone reduced mortality for at 28 days. And this was noted in patients that were hospitalized who were on oxygen or mechanical ventilation. So are you giving all the patients dexamethasone, and what steroid regimen have you found most helpful? And what dosing do you recommend for the obese patient? And this question, I would love to hear the perspective of both. But if Dr. Rivera, you want to start?
Sure. So again, as you know, you're talking about the recovery trial, right? So they saw some benefit in patients who were hypoxic
Correct.
or in mechanical ventilation, right? So if you go by that trial, you know, the dose of decanol is 6 milligrams for 10 days, right? Now, there's some patients who, despite being on steroids, they still have very high inflammatory markers, right? And they progress in their needs, oxygen needs, right? They go from 2 liters of nasal cannula to high flow, you know, in a couple of hours, right? Despite being on this therapy, and they end up in the ICU. Our practice is to actually up it, and up it, you know, significantly, at least for 5 days, right? So we do
As in a pulse?
yeah, we do Decadron 20 milligrams for 5 days, and then after that we do 10 milligrams for another 5 days, and that's how we've been practicing, especially those patients who come to the ICU either on very high dose of high flow, or they're intubated, or even if they need to be placed on ECMO, right? That's what we usually do. And we think that we might feel we see some benefit, and there's some studies out there showing that, you know, higher doses might be helpful for these patients who, despite the 6 milligrams, they still progressing. The question about, you know, for obese, so no, you know, the medications on these trials were not weight based, right? They were not, right? And they were fixed doses, just as we do, let's say, with asthma or COPD, right? You give, you know, 40 milligrams, 60 milligrams of prednisone, and then you wait and see that hopefully, you know, they start responding to it. I see weight-based steroids, usually autoimmune diseases, you know, organizing pneumonias, right? Those are the only diseases that I can think about, you know, that usually do weight-based steroids, at least in adults, right?
And somebody's asking if, in your experience, there has been any benefit in extending steroid administration beyond 10 days.
So right, so that's a very good question, right? And we have this discussion every day within my colleagues, right? There's patients who, after they get the 10 days, right, they still showing a lot of inflammation, right? They still in a lot of oxygen, right? So you can consider, you know, either extending it, right? Although the data is not there, right? Or the other thing you can do is just after 10 days stop it, right? As you would, and then watch them and see, right? Sometimes the numbers might rebound a little bit, but they're not clinically getting any worse. You can probably, you know, observe them. But for sure, we have patients that they've been steroids for 10 days, right? Even those high doses that I told you, 20 milligrams for 5 days, 10 milligrams for 5 days, we stop it, and then you see them, you know, all the inflammatory markers going up, and their X-ray actually, you know, getting worse. And what we usually do, we go back on steroids, usually back to 10 milligrams, and then slowly, you know, wean them off the steroids. The thing is that you have to worry about infections, obviously, and also criminal infections, right? PCP, but also any sort of bacterial infection and fungal and CMV reactivation. We have seen a lot of CMV reactivation also on these patients.
And somebody's asking if there is, when you're pulsing these patients or giving the higher doses of dexamethasone, is there any data that is behind that? Because where the person practices, they're running out of dexamethasone, and they say there's no way pharmacy's going to let us give triple dosing.
So, you know, dexamethasone, I guess it was chosen most of these studies because of the potency, right? But you can do any other steroids. You can do prednisone if they can take PO. They can do Sumedrol, right? So it doesn't have to be dexamethasone itself, right? But you know, again, you have to have a good reason to continue steroids for a longer time, right? And you have to be certain again that when you stop the steroids and they're getting worse, not because they now getting some sort of nosocomial infection, right? So it's a little bit of the art of what we do, right? Trying to figure out risk benefits, um, and and sometimes we just have to, you know, do it and hope that our decisions are sound.